Hello everyone, I am Ahmed Nasruddin and I am Professor of Neurology in Asyut University in Egypt. I am delighted today to welcome you all to the 65th edition of the MENASO Educational Academy Cerebrovascular Grand Round. Today's topic is very important topic. We will talk about stroke in the young from genetic to lifelong prevention. This session will explore the most recent advances and evidence affecting the evolving landscape of stroke prevention and management among young adults. Over the past year, our webinar series has engaged a worldwide audience of more than 5,000 participants, reflecting wide reach and value of our educational initiatives. This success has been made possible through the contribution of exceptional faculty of 45 speakers, including selected group of renowned regional specialists as well as international professors and consultants. Today, we are honored to host this distinguished panel of experts who will share their research and valuable clinical perspectives and engaging discussions throughout the program. Through this exchange of knowledge, we aim to elevate the standard of care and improve clinical practice and improve also patient outcome, both regionally and globally. So it's now my pleasure to welcome my co-moderator for today's session, Dr. Sib John. Nice to see you, Dr. Sib.
Thank you very much, Professor Ahmed. Good evening, good morning, good afternoon, wherever you're joining us from the world. And thank you all for attending this MENASO webinar. So as Professor Ahmed discussed, a very important topic today, we are going to be discussing stroke in young. And for those living in the MENA region, this is definitely a huge problem where a lot of our patients have stroke very early. So I'm very excited, to dive into this and listen from our experts. So the format of our webinar tonight, there'll be two case studies. Dr. Norhan Bakri and myself will present two short cases. And then we'll go into the program itself, where we have two distinguished speakers. We'll have Dr. Katrina Ignacio, who's going to be talking about understanding stroke in the young. And for the local perspective from Oman, we have Dr. Muammar Al-Amri, who's going to be talking about what we see differently in our region for young stroke. So without much delay, let's start the program. So it is my honor to introduce our first speaker, Dr. Norhan Bakri. Dr.
Hello.
Norhan is
Nice to meet you all. Good morning, good night, and good afternoon. I will be presenting the first case of this webinar. Let me just share my screen. Okay. There it goes. Is the PowerPoint, can everyone see my PowerPoint?
If you can make it full screen.
Yeah. Okay, without further ado, I'll just I will be presenting the first case scenario of this webinar, which is basically about competing mechanisms, competing therapies, and managing stroke in atrial fibrillation patients requiring vascular stenting. Our patient or our case today is a 50-year-old male patient, hypertensive, controlled on treatment, not known to be diabetic, not known to be dyslipidemic, doesn't smoke, no prior history of TIA or stroke, and no family history of premature stroke. The patient presented with an acute onset of vertigo, nausea, and unsteadiness of gait. His first medical contact, he consulted the ENT department where a presumed diagnosis of vestibular neuritis was done. The rationale for this diagnosis was that the patient was young of age and had low vascular risk burden, and also the vertigo and nausea pattern. The point I want to make here is that just because the patient is young of age and has reduced vascular risk burden doesn't exclude vertebral basilar ischemia. In this patient, within 2 to 6 hours, the vertigo intensified, it became persistent rather than positional, and the vomiting increased in frequency and became unrelenting. Within 12 hours, the unsteadiness became frank cerebellar syndrome. The patient was unable to walk without support, and within 24 hours, the patient was completely bedridden. Thus, the clinical diagnosis of vestibular neuritis was completely incompatible with the symptoms that the patient is now presenting with. The patient presented to the ER after 24 hours, and neurovascular assessment was initiated and non-contrast CT was done. Neurological examination found that there was bidirectional nystagmus, positive skew deviation, and normal head impulse test, all pointing towards a central posterior circulation problem rather than a peripheral vistulopathy. Also, motor and coordination findings showed that both upper and lower limbs had a motor power of 5, but the patient had severe dysmetria, more on the left than on the right, positive finger to nose test, positive heel to shin test. Tandem gait was impossible. The patient was unable to ambulate at all. And the NIHSS score on admission was found to be 3, scoring 2 points for bilateral ataxia and 1 for dysarthria. And thus, the NIH score in this patient significantly underestimates the posterior fossa stroke severity. Like this patient, a patient may present with a score of 3 and be completely disabled by cerebellar function. Immediate action was taken since the patient was outside the 4.5-hour window. IV alteplase wasn't feasible. Non-contrast head CT was done and showed there was no intracranial hemorrhage, and thus dual antiplatelet therapy was initiated. High-dose statins was initiated. Blood pressure was managed so as to avoid over-aggressive reduction in hyperperfusion. Symptomatic support was initiated. The patient was admitted to the stroke unit for continuous monitoring, and MRI was ordered. Upon MRI findings, there was a left lateral medullary infarction or hyperintensity in the DWI. Then CTA was reported, and these were our findings. They were suggestive of diffuse atherosclerosis involving both the carotid and the vertebrobasilar systems. Basically, occlusion of the left ICA, stenosis of the right ICA, and occlusion of the left vertebral artery. This was the CTA report. Neurovascular consultation was done, and the decision that was taken is that the patient underwent stenting procedure in the left vertebral artery and the right internal carotid artery with good technical outcomes. Then comes the dilemma. Post-procedure, during continuous cardiac telemetry in the stroke unit monitoring, the patient was found out to have atrial fibrillation, which was not present on initial ECG admission, thus diagnosing the patient with paroxysmal atrial fibrillation. This was a finding that fundamentally changed our entire secondary prevention strategy, because if we didn't have the continuous cardiac telemetry monitoring, this diagnosis would have been missed, and leaving the patient to be on dual antiplatelet alone with an unrecognized cardioembolic mechanism and high recurrence rate. The CHAD-VASc score of this patient was found to be 3. Which brings us to our therapeutic dilemma, and one of our main points of discussion for this case. Which treatment should the patient continue on? There were 2 simultaneous indications with conflicting pharmacological results. Should the patient continue dual antiplatelet to prevent instant thrombosis? Dual antiplatelet has proven efficacy for atherosclerotic stroke prevention, and the Chance Point trial showed that dual antiplatelet is superior to aspirin alone for early minor stroke. Or should we give the patient anticoagulation, as paroxysmal AF is a class 1 indication for oral anticoagulation, and even in the absence of the CHAD-VASc score, because the patient has a current stroke. An AF may have been the primary mechanism and not just a bystander finding. So, and the patient had a CHAS-VAT score of 3, which means there was an annual recurrence rate of more than 5% if the patient continues without anticoagulation. Obviously, we couldn't put the patient on triple therapy, oral anticoagulation and dual antiplatelet, because that is totally not recommended. The hemorrhage risk exceeds the ischemic benefit, and thus a single strategy must be chosen. For this patient, we chose to extrapolate our strategy from the Augustus trial on AF patients with coronary stenting, and which found that giving a combination of apixaban, a direct oral anticoagulation with long-term clopidogrel, was found to have better or safer less risk of hemorrhage than other combinations. The patient was also given high-dose statin therapy and referred to blood pressure management and cardiac follow-up and rehabilitation, daily physiotherapy, occupational therapy, speech and language therapy, and for follow-up at the outpatient clinic. The main discussions of our case today would be the stroke misdiagnosis in young adults. Just because the patient was young and had a low vascular risk burden, there was a delay in the diagnosis of the patient, and we have a paper on that, and and in hospital delays in the use of thrombolytic therapy for patients with acute ischemic stroke in rural and urban Egypt. There was a problem with the type of help-seeking behavior among the population. A lot of people under-recognize stroke symptoms, especially those of posterior circulation, because sometimes they can come similar to other system affections, like in this case, and patients go directly to other clinics, other private clinics, ENT clinics, ophthalmology clinics, general practitioners, internal medicines. And this leads to a delay in the diagnosis and loss of the opportunity to use the IV thrombolytic therapy for the patients. The second point for our discussion is the dilemma of when we find a patient who has a cardioembolic risk and an atherosclerotic risk, and which drugs should the patient continue on for the best ischemic prevention, but at the same time, the least risk of hemorrhage. And that brings me to the end of my case scenario.
Thank you very much for this nice case. Brings up multiple discussion points. I think we have a couple of minutes. Dr. Ahmed, can I ask a couple of questions?
Yes, of
Yes.
course. Yes.
So the first point, and again, we have 260 people online, is your point about NIHSS, right? In posterior circulation stroke, this can completely miss significant disabling deficits. So I think that is a big learning point for the audience, that please don't rely exclusively on NIHSS, especially for posterior circulation strokes. I had a question. You went briefly over your CTA. You said the left vertebral was occluded?
Total occlusion of the left internal carotid, and there were also high-grade stenosis of the right internal carotid. That's why the interventionist placed the stent in the right internal carotid, because the left was totally occluded in digital subtraction angiography, and the posterior circulation left vertebral artery was high-grade stenosis. In
High-grade
CT angio,
stenosis.
yes, in CT angio it was closed, but in digital subtraction angiography it was high-grade stenosis, and right vertebral artery was patent. Actually, there was an argument between us and the interventionist. We wanted them to do balloon dilatation for the vertebral and place a stent in the internal carotid, but his point of view is that it's better to place a stent in the vertebral and internal carotid. It was a matter of debate between we and them, but the patient at the end got 2 stents, one in the left vertebral and one in the right internal carotid, because he was young and
Let me ask you, would you have changed your management regarding the vertebral stenting if you found the atrial fibrillation before the procedure?
Actually, no, because actually it was a dilemma, but I want to change my my management plan, because the left was totally occluded and right has high-grade stenosis, and also left vertebral artery has grade stenosis. So this patient has only one patent artery, the right vertebral artery and basilar. So it's high risky for 50 years old. So I think what we did was the right management decision. Patient is improved completely, and now he's living with mild ataxia, but he's much better after this intervention. Actually, the problem is that no neurological trial speaking about what we should do in patient with atrial fibrillation and extracranial or intracranial stent. All the trial are extracted from cardiology trials and from cardiologic patient who have AF and coronary stents. That was the problem.
Yeah. So, audience, you will definitely have time once the speakers have finished to ask questions. We will dedicate enough time. But a couple more comments I had is, again, this was a 50-year-old gentleman, but you could see the amount of accelerated athro in this person. And this is also not uncommon in our region. So just because the patient is young, do not suspect it may be, something non-vascular.
Exactly, that's the dilemma, that the people think that the stroke is a disease of elderly. That's why he was misdiagnosed at the first, that is vestibular neuritis. Although stroke can occur in young adults also, especially in our regions. I don't know what is the cause. It is a genetic or sometimes sedentary life, type of food, climate change, because our region has warm weather. I think all these factors make interact with each other to produce this younger onset of stroke.
Thank you.
So I think it's now my turn to introduce my co-moderator, and I'm delighted to introduce him, Dr. Sibijoun, who will present the second case. Dr. Sibijoun is a consultant vascular neurologist and neurointerventional surgeon at Cleveland Clinic, Abu Dhabi. He's a clinical associate professor at Cleveland Clinic Lerner College of Medicine, USA, and Khalifa University College of Medicine, United Arab Emirates. Trained in neurology and vascular neurology at Cleveland Clinic, Ohio. He holds an American Board of Certification with vast expertise in cerebrovascular diseases. He is also prolific researcher, contributing to international trials and authoring over 75 publications. Dr. John is engaged in MENASO and MENASINO, chairs United Arab Emirates Vascular Neurology Formation Thrombectomy 2020, and he also reviews for multiple journals and serves on the Clinical Neurology and Neurosurgery Editorial Board. We are welcome, Dr. Sibijoun, and we are looking forward to hear your presentation.
Thank you very much. Thank you for your kind introduction. So do you see my slides? Do you see my slides?
Yes.
Okay. All right. So interestingly, I have another case of a posterior circulation stroke. I'll be mindful of time, so if I go a little bit fast, please apologize, and we can get back after the other speakers for Q&A. All right. So I do not have any disclosures. So young female, healthy without any risk factors. She had a left cerebellar stroke in 2024. This was in another country, and we do not have the etiology, but she was started on aspirin. She completely recovered, and she is compliant on her medications. After that, she moved to Abu Dhabi. And in October 2025, she had episodes of loss of consciousness with dizziness while she was standing in a bus. Nothing much in terms of history. She says she just blacked out. In December 2025, she had 2 episodes of brief right-sided numbness, which resolved. So clinical TIAs were suspected, and clopidogrel was added to aspirin after the second episode. This was also at another outside hospital in Abu Dhabi. In January, she came to us. So she presented to Cleveland Clinic with left-sided weakness. Her NIHSS was 6. She had left-sided hemiparesis and ataxia. Symptoms were disabling. She was within the window. She was given IV tenecteplase. Exam was completely unremarkable. Otherwise, review of systems was nothing pertinent. She is married, never pregnant. These were the meds, antiplatelet, statin. So this is the current MRI. So you see this right thalamic infarct. You see a small right cerebellar infarct, not much in terms of stroke burden. This is a previous infarct. This is a cerebellar infarct from 2024. I can tell you, I'm just showing you one slice, but her flare was completely normal otherwise. And this is her SWI sequences, no microbleed. So essentially a very, very clean looking MR. So what would you do? You would probably work up your usual stuff, and this is all the usual stuff. Essentially, everything was normal, right? We did a TTE, we did a transesophageal, autoimmune vasculitis panel, hypercoagulation panel, all were normal. So kind of stuck. So initially when she came in for the stroke code, a CTA was done and was normal, reported as normal. And this is it. That was super fast. But essentially, if you kind of go through it, vertebral artery origins are normal. There is no dissection anywhere. There's no, intracranial stenosis. Everything looks pretty normal. But I spent some time on this, and there were a few things which caught our eye. And these are coronal MIP images, and you can see that there's kind of redundancy in the V3 segments of the vertebral arteries, bilaterally left greater than right. And you could see a few very subtle irregularities. If you scroll fast, you would miss this so easily. But this is the V3 segments, some subtle irregularities. And then the answer was kind of, right in front of our face. And this is it. So essentially what you see here is the dens is projecting well into, the foramen magnum. And this is a case of basilar invagination. And I will show you more how this was affecting. So this is your C1. The atlas is assimilated with the occiput, and then you can see the C2, the dens is projecting well into the foramen magnum. So we did an angiogram, and this is the angiogram, and you see something is going on over here. And if you look at oblique images, this becomes more obvious. You can see this lesion over here. And what is this? This looks like a deep kind of cleft with causing stenosis. Is this just a stenosis? Is this a web? So we published a case of vertebral web, fairly uncommon, which looked something very similar like this. So webs, as you know, is more common in the carotid posterior bulb. But in this, you could see it in the V3 segment also. And it looked very similar. Or is our case a dissection? We did not know. Anyway, I did some dynamic testing. So what you see here is the patient turning the head to the right. And we are doing a left vertebral artery injection. And what you can see is when this patient turns to the right, the vertebral artery completely occludes. And you can see that on the lateral also. So here's the artery coming up and completely occludes in the V3 segment. And when the patient turns to the left, this is a right vertebral artery injection. The right vertebral artery completely occludes. So essentially, this is a case of bilateral vertebral artery occlusion. Thankfully, one vertebral artery stays open when she turns to one side. So the contralateral stays open, but essentially both were getting closed. So what's the final diagnosis? This is a bilateral Bow-Hunter syndrome causing vertebrobasilar insufficiency and strokes from dynamic rotational vertebral artery stenosis and occlusion, plus minus whether there's a dissection over there, and this is related to basilar invagination. So very, very kind of cool case, something that we don't really think about which caused this. So I have about 4 more minutes. So neurologists don't think about these things much. If you have a surgeon in the room, a neurosurgeon, they're a lot more used to looking at these issues, but there are a whole host of conditions that can cause abnormalities at the craniovertebral junction. And if you think about dynamics, the occiput and the C1, this is mostly flexion extension. And then you have your C1, C2, this is your, your lateral rotation. But also there are a whole bunch of ligaments that also stabilize the craniovertebral junction and assist in stability with movement. So here is the segments of the vertebral artery, and specifically the V3 segment. So as it goes out of the C2 foramina, then there's a horizontal part on top of the C1 this is especially prone to dissections. And in a case of craniovertebral junction disorders, either atlantoaxial dislocation or basilar invagination, this could be stretched, and that could contribute to things getting kinked and causing occlusion, essentially like a bow hunter syndrome. This is completely unrelated to the more usual forms of bow hunter that we are used to, where there's a lot of osteophytes, it's an older person with a lot of cervical degenerative disease. So again, as neurologists, these are the kind of symptoms that we are familiar with. There's compression of the cervical spinal cord, lower cranial nerves, brainstem, and classical symptoms associated with that. But keep in mind that CVJ, although very rare, can cause vertebrobasilar insufficiency and posterior circulation stroke. Some clues that we may look for if people have a short neck, low posterior hairline, limited range of movement. These are typical kind of triad for Klippel-Feil syndrome. But you could have, other dysmorphisms which may point you that there may be something craniovertebral going on. These are syndromic associations, mucopolysaccharidosis, etc. Very simple, some markers that we may use. So, example, if you look at this coronal image, there's these McRae and Chamberlain lines, but essentially your dens should be below these lines, right? So just a simple look at a sagittal section of your CTA. If you see that this is encroaching way higher, then something is going on, basilar invagination in my case. So basilar invagination is associated with Chiari-1 malformations and syringomyelia. And of course, you have to look at, whether there's stability with atlantoaxial dislocation. I'm not going to go into management much, but this patient had a very large fibrous band that was actually kinking the vertebral artery on the left side. This was decompressed surgically, and this is the post-op image of the vertebral artery, which shows that it's completely relieved. So some take-home points. As neurologists, we don't think about this much, but most common cranial nerve, most common presentations of CVJ is your usual when there's compression of the brainstem, cervical cord, lower cranial nerves. But think about CVJ abnormalities if you have posterior circulation stroke, if they are indeterminate etiology, if they are recurrent, especially if you have V3 segment dissections. Consider at least a screening cervical spine X-ray. And remember the radiological lines that can easily help us, determine whether there's a case of basilar invagination. And remember associations of Chiari and syrinx. Thank you very much. I know it was quick, but I'm happy to take questions later on also.
Thank you, Dr. Sebi, for this interesting case. Actually, my first impression was that it could be an ICAD, intracranial atherosclerotic disease. So my question is, the ICAD is common among population in United Arab Emirates?
Yeah, extremely common. So ICAD, just like in your case with accelerated atherosclerosis, is extremely common. Maybe not as common as, let's say, China, where up to 50% of strokes are related to ICAD. But I would say at least, 25 to 30% of our cases are related to ICAD. Good. Again, I'm happy to take questions towards the end, but we are moving well in our program. So it is my pleasure to introduce our first main speaker for our webinar today. Welcoming Dr. Katrina Ignacio, who's going to give us the first talk. She is a stroke fellow at the University of Calgary. She did her residency in Philippines and subsequently doing a fellowship, a lot of experience in the stroke field, with plenty of publications from Philippines. And today she's going to be talking about an overview and, I guess, new developments in young stroke. Dr. Katrina, take it away.
Thank you so much for the kind introduction, Dr. Sebi. Let me just share my screen. Please let me know if you're seeing my slides.
Yes, we do.
Okay, perfect. As Dr. Sebi mentioned, I'm one of the stroke fellows here in Calgary, and I thank the MENASO first for this kind invitation. Thank you so much, Dr. Norhan and Dr. Sebi, for such interesting presentations. So the title of my talk today is When Stroke Strikes Early, Understanding Stroke in the Young. So I was hoping to take you on a brief but informative discussion on stroke in the young. I'm not an expert on this. I've done some studies, but I took a deep dive and hopefully we can all learn together. So here is a brief outline of my talk. We'll first touch on the definition of stroke in the young, the epidemiology, how common is stroke in the young, its etiology and risk factors, workup for stroke in the young, acute management, prognosis and complications, and some take-home messages or pearls for your next young stroke patient. Now, who counts as young? When we say stroke in the young, what's the upper, what's the lower age limit? So
Dr. Katrina, you are muted.
Your audio.
Dr. Katrina, we don't hear you. Yes.
Sorry.
No.
Yes. Okay. Perfect.
Yes.
Thank
Now
you.
we hear you. Yes.
Sorry about that.
Good.
Sorry. So the definition is between 15 to 18 years old, whereas the upper age limit is between 40 to 65 years old. Now, while there is no consensus on the age cutoff, it's important to remember why there is a definition for stroke in the young in the first place. So the reason behind this is because usually there are different etiologies compared to stroke in older adults. Stroke in younger individuals have unique risk factors, and they require a more expanded workup than your typical patient. They also have a different prognosis, and these individuals have distinct family, social, and professional roles. Now, what about the incidence or the epidemiology of stroke in the young? So, as I was listening to the different talks, it's very important to note that actually stroke in the young incidence has actually been increasing over the past years, and there's actually a disparity in epidemiology between high and low middle income countries. So in high income countries, the median age of first stroke is at 70 years, whereas in low to middle income countries, the median age of first stroke is actually 5 years younger. And whereas in high income countries, 5 to 15% of strokes occur in the young, this is actually higher in LMICs, where 14 to 25% of strokes occur in the young. The exact reasons for this increase is not entirely known, but it's likely due to the contributions of traditional and emerging vascular risk factors, which we'll be discussing in a bit. And also the disparities are not clearly understood, but they may partly reflect differences in social and economic development in these countries. There are also certain sex and age disparities when it comes to the epidemiology of stroke in the young. So among younger individuals, the age standardized incidence rates, mortality rates, as well as disability adjusted life years are actually higher in men compared to women. The age standardized prevalence rates, however, are higher in women compared to men. And as age increases within this subgroup of patients, prevalence, mortality, and disability adjusted life years also increase. So what are the different risk factors for stroke in the young? So as we all know, you have your traditional vascular risk factors. These are also applicable to stroke in young patients. These include hypertension, diabetes, dyslipidemia, obesity, smoking, diet and substance use. All of this we know, but there are also non-traditional risk factors. So for example, in the cases presented, arterial dissection, as well as vasculopathy and vasculitides, conditions such as Fabry, MELAS, CADASIL, inherited and acquired thrombophilia, malignancy, PFO, and factors unique to women such as estrogen-containing contraception, pregnancy, and migraine. Now, aside from the incidence of stroke in the young increasing, we've also noted that the prevalence of stroke risk factors has also been increasing throughout the years. So here is a study done in the nationwide inpatient sample where they compared, between the years of 2003 or 4 and 2011 to 2012. You note that the prevalence of stroke risk factors such as hypertension, dyslipidemia, tobacco use, obesity, both in males and females, have actually increased over the years. And in fact, the prevalence of having multiple risk factors among younger adults, nearly doubled. So some are saying that, with the increase in risk factors, this could also plausibly explain why the incidence of stroke is increasing in these young patients. Now, interestingly, there's also what we call emerging risk factors. Now, please note that further research is needed to determine whether these associations are actually causal in nature and even specific to young patients. But there have been hypotheses that certain emerging risk factors like pollution, high temperature, stress, and long working hours, as well as depression, are potential contributors to these unfavorable time trends in stroke incidence reported at young ages. Here at Calgary, we performed an analysis of one of the trials we conducted in patients who were enrolled between 2019 and 2022. So this was just a small sample of patients, but we just wanted to show you that of the patients included in this sub-analysis, we found that hypertension was most common. Cardiac pathologies were also observed in a smaller proportion. In patients, even in young patients, we found that there was around 10% with intracranial atherosclerosis, and carotid or vertebral artery dissection was present in 9%. But what about bigger studies? Similarly, and I'd like to share a larger multi-center prospective study conducted in the Netherlands with over 1,000 patients. Here, they identified risk factors leading to ischemic stroke and used different classification schemes such as TOAST, ASCOD, as well as a pediatric classification scheme. And the results were interesting, and I'll share with you. So they proposed that, using the pediatric classification scheme for a young stroke population might actually provide more insight in terms of risk factors and etiologies of stroke in the young. So as you know, our TOAST criteria, it's quite limited, and I'll show you in a bit. But here's an example of the different risk factor categories in the IPSS classification system. So they have almost 10, and you can have arteriopathy, cardiac disorders, similar to our TOAST criteria, but they also include, for example, chronic systemic conditions, prothrombotic states, acute and chronic head and neck disorders, infection, and atherosclerosis related risk factors. Now, note that when we say risk factors, these are not necessarily synonymous with cause, but it's interesting because using this classification system, it actually expands potential risk factors for this young stroke population. Now, here are the results of their studies. So what are the different causes according to TOAST criteria? So in general, using TOAST criteria, around 1/4 of patients, of these 1,000+ patients, were classified as having cryptogenic strokes. Other determined causes, so for example, dissection, hypercoagulable causes, were around 21%, cardioembolic causes 17%, atherothrombotic in 13%, and smaller proportions for small vessel disease, multiple causes, and large artery atherosclerosis. Now, note that patients with cryptogenic stroke were actually younger compared to those with non-cryptogenic stroke. And again, even within this young stroke age group, the etiologies changed. So as you note, as the age increases, there's a higher proportion who are diagnosed with large artery atherosclerosis as well as small vessel disease. And there are fewer who have cryptogenic or undetermined causes with increasing age. Now, this slide is what the millennials call too long, do not read. But the point of this slide is basically we want to demonstrate that there are multiple potential etiologies and risk factors for ischemic stroke in young adults. So like we mentioned earlier, arteriopathies, cardiac causes, prothrombotic causes, acute head and neck conditions, all of those are potential risk factors, etiologies. And so while I can't take you through all of them, I'll try to take you through the etiologies that are important and hopefully that we will encounter in our practice. So when we encounter a patient with stroke in the young, what's a diagnostic approach we can take for these patients? So here I'm sharing an algorithm that was proposed by the Ischemic Stroke Phenotyping System in 2025. And this actually applies to all stroke patients, but the reason why I wanted to share it was because they tried to address the gap in the existing stroke schema, our TOAST, our ASCOD, where there's not exactly a age-specific risk factor or appropriate testing. So here they actually have recommendations on patients who are, let's say, less than 60 years old. So we'll discuss that. And also they redefined ESUS according to, or embolic stroke of uncertain significance according to modern evidence-based criteria. So let's start with what they call their first pass or minimum first pass workup, like a first year workup. So similar to our presentations, what are the first things that we order when we encounter a patient with stroke in the young? So aside from a comprehensive history and physical exam, we do brain imaging. So that's to see the parenchyma, whether it's a CT or MRI, vascular imaging, aortic arch to vertex study with a CTA or an MRA, and lab tests which include your CBC, electrolytes, coagulation labs, a D-dimer, lipid panel, A1C, inflammatory markers, a drug screen in this young population. So for example, urine cocaine, methamphetamine, and consideration of HIV and syphilis if clinically indicated. Cardiac imaging, they suggest to include an echocardiogram with a bubble study to detect potential right to left shunts. Age-appropriate cancer screening is also recommended. Now, the point of this first pass or minimum first pass workup is to allow us to identify major sources of embolism, atherosclerosis, or other defined mechanisms, and classify some strokes as small vessel disease. So with that first pass, we can identify these etiologies. Now, what about patients who turn out negative in all these tests? So now they go to this group called patients with an undetermined cause of stroke, but that there is still certain workup that we can do in order to try and identify what causes their stroke. And I'll expand on this in a bit, but these are the different etiologies that are related to this minimum second pass workup. So first is antiphospholipid antibody syndrome. So around 20% of strokes in patients less than 45% are associated with this syndrome. And so in patients who are negative for that first pass workup, should consider testing, anticardiolipin, lupus anticoagulant, and beta-2 glycoprotein antibodies, especially in patients with recurrent ESUS or known or suspected SLE, and features of the syndrome. So, for example, on history, taking an OB-GYN history is important, especially for female patients. So have they had, miscarriages or venous thrombosis as well? And once we detect this, it's important to put them on proper treatment. So typically, we would do anticoagulation with warfarin with a goal of INR 2 to 3. So that's one important etiology of stroke in the young that we can detect. Now, another etiology that is important in stroke in the young is ICA dissection or vertebral artery dissection, as our cases have shown. So if, for example, usually we detect this already on our, let's say, CT angiogram or MR angiography. But if, for example, we are not able to detect this, but the patient we're highly suspecting to have dissection, so for example, they have new or worsening neck pain, headache, or a Horner syndrome, and their CTA and MRA is equivocal, we can actually perform MR angiography with T1 fat suppression. And the purpose of this is to visualize an intramural hematoma. Now, I wanted to share an interesting image that I read on a case report, and this is what they call the puppy sign. And this image actually shows bilateral ICA dissections. So the sclera of the, if you're seeing this, the sclera of the puppy is actually the hematoma, and the residual lumen, this one, are the pupils. So around 2 to up to 25% of stroke in the young is caused by dissection. They're usually more common in the upper cervical spine portion of your ICA. And while they can occur from trauma, structural anomalies, most of the time they're actually idiopathic. And treatment options include antiplatelet or anticoagulation. Now, another important mechanism or etiology for stroke in the young is our genetic conditions. So examples of cerebral small vessel disease caused by, monogenic causes of stroke include CADASIL, CARASIL, COL4A1. So in patients with evidence of lacunar infarcts or small vessel disease on MRI with no or minimal risk factors, we should be thinking of these conditions. These are a lot of conditions, but as an example, in this slide, I'm showing an MRI of a patient with CADASIL. So you see typically small, deep infarcts on FLAIR. You can have confluent white matter hyperintensities in your usually anterior temporal lobes. And when you look at your GRE or SWI sequences, you can see microbleeds. Other genetic causes of stroke, especially stroke in the young, include sickle cell disease, Fabry disease, So these are all things that we should be, thinking in the back of our minds if all our first pass tests turn out to be negative. Another important stroke etiology among young stroke patients is a patent foramen ovale. So if, for example, again, in our first pass workup, we said we're going to do an echocardiogram, transthoracic, with a bubble study. And one of the reasons is to detect a PFO or a right to left shunt. But if, for example, workup is negative, but we're still suspecting a PFO, then we could do a TEE, so a transesophageal echo, intracardiac echo, or transcranial Doppler with agitated saline contrast, or what we call a bubble study. And the point is to detect right to left shunts between the atria. So who should we be testing? Patients less than 60-year-olds, so your young stroke patient, especially with clinical clues of paradoxical embolism. So for example, if on history they seem to have onset during Valsalva or after long travel, then we should be highly suspicious of this. However, note that up to 25% of your general population have PFOs, and this is the reason why we have our different scoring system. So for example, you have your ROPE score calculator as well as your Pascal classification system. And the point of this is that if you have a high ROPE or Pascal score, then then the stroke is likely related to your PFO. And in fact, 40 to 50% of young cryptogenic stroke patients are attributed to PFO-related strokes. So their risk is actually 5-fold higher compared to older adults. Other etiologies we should be bearing in mind include cardiac tumors. So, for example, these are usually detected on echocardiography, and they're actually rare. But again, if, for example, everything's negative and you're still, thinking about what could be the etiology of this stroke in my young patient, then one thing to consider in patients who are less than 60 years old is a TEE or a cardiac MRI with GAD. So just note that it's actually these myxomas or fibroelastomas occur in less than 1% of ischemic stroke in 18 to 49-year-olds, but the mean age of onset of both these tumors are actually in young patients. So a mean age of 42 for myxomas as well as mean age of 55 in fibroelastomas. Another important etiology, although it's actually more common in elderly individuals, but can occur still in younger individuals, include cancer-related strokes. So stroke can be your first presenting sign of cancer. And we have to ensure that in our patients, they have guideline-directed screening or up-to-date screening. So for example, if your female patient, mammography, colonoscopy as appropriate, and low-dose chest, CT, and PSA testing. So who do we typically test? Actually, here in Calgary, in stroke in young patients, or if, for example, the first pass testing is negative, we actually include D-dimer already during as soon as they arrive. But other tests or other reasons that would raise our suspicion for cancer-related stroke include what we call a 3-territory sign on MRI. So, for example, if 3 different territories are affected with strokes, this has been shown to be specific for malignancies. A high D-dimer, which is defined as greater than or equal to 2.5, and of course, on history, if they present with constitutional symptoms or a symptom related to an organ system, then we should be testing them. I also wanted to share this diagnostic flowchart. So this is a review on ischemic stroke in the young, and in this particular article, they had provided a nice diagnostic flowchart for young patients with ischemic stroke. And what I liked about this is they suggested an ABC framework. So basically everything we discussed is here, but they said that your first pass test should always include arteries. So, vessel imaging, blood, so all your blood tests, as well as cardiac function. Okay. What about in terms of acute management? What do similar criteria apply? Is there something special for stroke in the young patients? So in general, for stroke in the young, the same criteria for acute management apply. So eligible patients, for example, for IVT would be those within 4.5 hours of onset, showing signs of disabling deficit based on your CT-CTA. There is, in the guidelines, in our guidelines, there is a caveat that for adolescents, the decision to administer IVT should be based on your clinical judgment, presenting symptoms, patient age, and if possible, consultation with a pediatric stroke specialist. Now, in our thrombectomy guidelines, it's patients who are eligible are those greater than 18 years or equal to 18 years of age. There's currently no evidence for EVT in pediatric populations, although we have done EVT in pediatric stroke patients here, but the decision should be based on potential benefits and risks of therapy. One of the questions we had, which is why we did this sub-study of our trial, was whether or not there was a difference. Because here in our center, we actually have been starting to administer tenecteplase compared to alteplase in terms of outcomes in our young stroke patients. And in our small study, we found that tenecteplase appeared to be both a safe and effective alternative to alteplase, and it showed comparable rates of mortality, intracranial hemorrhage, and serious adverse events. There was some signal for potential for improved 90-day outcomes, but again, this was not a randomized control trial. It was based on RCT data, but it was a sub-study, so it's definitely not causal in relationship. For acute management, though, one thing to consider is that the risk of malignant infarction is important in young patients. So young patients with large hemispheric strokes who are at high risk of developing malignant cerebral edema should be considered for decompressive hemicraniectomy. In fact, even posterior fossa strokes require close monitoring due to the risk of malignant cerebellar edema. And this should be considered as a life-saving measure in these patients. So we always inform patients and their substitute decision makers that even though you undergo this procedure, poor outcome, we expect that there will be disability after. So they should be willing to accept this risk of disability. Now, what is the prognosis of stroke in young adults? So while we think that, maybe it's benign, maybe they're younger, in fact, our long-term studies have actually been showing that young stroke and even TIA survivors show a higher long-term hazard of adverse outcomes. So in this particular longitudinal study, even after adjustment of comorbidities, young patients showed a 7-fold increased hazard of the composite outcome of death, stroke, MI, and long-term facility admission. At 5 years, this was also increased compared to their matched controls. Long-term as well, patients who've had stroke in the young after 10 years, actually a third of them, or 37% of them, have an MRS of greater than 2, so poor functional outcome. Impairment in activities of daily living was also noted in up to 15% after 10 years. So it's not as benign as we think. And also because this is a specific population of, young adults who have a lot of functions in society, there are a lot of complications: medical, functional, psychosocial, and economic. So, for example, in terms of mortality, the risk of death, although low in the first year, around 2.4%. Increased in 10 years to around 5.5 to up to 16%, and half of which were attributable to vascular causes, which is why we should keep in mind prevention. Stroke recurrence rates at 10 years could reach 20%. And functional outcomes, although 75% up to 10 years are MRS 0 to 1, the long-term burden remains high. 1/3 of these patients suffer from post-stroke depression, around 40% from post-stroke anxiety. We did a meta-analysis on this. But also important to note are up to 85%, in observational studies have reported post-stroke fatigue. So these are important questions to ask your patients after their stroke. Also, not returning to work is a frequent adverse outcome after stroke in young adults. So a study on return to work showed that, at 5 years, almost 50% of these patients were not working. So all in all, it's not such a benign disease, and the impact is quite significant on stroke on young patients. So take-home messages, what are 8 pearls for your next stroke in the young patient? So stroke in young is different from stroke in older adults. The incidence is rising, and this could be due to risk factors also increasing. The etiologies differ from stroke in older adults, and we should use a tiered workup in evaluation. While acute management is similar, there is a higher risk for malignant infarction in these patients, and long-term prognosis can be poor because the prevalence of their psychosocial and economic complications is high. Thank you very much.
Thank you very much, Dr. Ignacio. A very big topic summarized in a very short time. So thank you very much. We will keep moving. I'll ask Dr. Ahmed to introduce our next speaker.
Thank you, Dr. Katrina, for your nice presentation. So I would like now to introduce our last speaker, Dr. Muammar Al-Amiri, who will present young stroke in the Middle East region, what we see differently. Dr. Muammar Al-Amri is a consultant stroke neurologist and head of neurology department at Sultan Qaboos Hospital in the beautiful Salalah, Oman. He is highly qualified and has dual certification, has MD degree and board of internal medicine, and he was serving as a specialist of internal medicine. Then he took an neurology fellowship in stroke and neurology in Alfred Health Hospital, Melbourne, Australia. And he has made a significant academic and clinical research contribution with several publications and peer-reviewed journals. He also is actively involved as a co-investigator in multiple international randomized clinical trials, reflecting his commitment in advancing stroke care and neurological science in Oman and Middle East. Welcome, Dr. Muammar, and we are looking forward to hear your very interesting presentation. Dr. Muammar, you are muted.
Okay.
Okay.
I hope you can see me and see my slide and hear me.
Yes.
Thank you. Thank you, Prof. Ahmed, for the kind introduction. And many thanks to MENA Stroke Organization for the invitation, for organizing this webinar, very informative webinar, as well as for all the educational activities and services you are providing. So, and also actually many thanks to everyone and to the people who are still online till this last part of the webinar. So my task was to share with you some data from our region, Middle East and North Africa region, and I hope I will do so. It's not moving. Is it moving?
Yes, sir. It's moving.
Yes. Excellent. So over the next 25 minutes or so, I will be touching briefly on burden of young strokes. I will start from where Dr. Katrina has concluded or ended her presentation. Then I'll be sharing some data on epidemiology from MENA region about stroke in young, and then more clinical data, and then we'll end up with reviewing the availability of stroke services for this age group, and we'll end up with some conclusion and take-home messages. So as Dr. Katrina was saying, it's young stroke is a major diagnosis. It's not just an acute event. It has lifelong consequences, and it has a huge impact on different domains, physical, cognitive, emotional, social, educational, and career impact. And all stroke patients, particularly young people, they are losing their life years as well as quality adjusted life years because of the stroke. And this is actually an interesting article done in Australia where I did my fellowship, and they have actually estimated. So it was done by Tan et al. They have estimated the number of life years lost as well as healthy life years lost in stroke patients compared to general population. So if you look into the first column, people less than 25 years of age, they are losing up to 10 years of their life years and 15 to 16 of quality adjusted life year. And this is hold true for all other age groups as well. The other table here is showing what is called utility score, which is an indicator of quality of life, which is affected as well in strokes. So if you look into the first arrow, for example, this is the age group like less than 40 years of age, general population who did not suffer from stroke. Their utility score is 0.85. And this is dropping by 15% in their peers who are suffering from stroke. Again, this is true for all other subgroups. So as we said, it has a huge impact on life. Moving to the epidemiology, Dr. Katrina also shared an interesting article about the epidemiology, and I got another article discussing the global differences in incidence in stroke young. By Bout. So in this map, the brown color indicates like the highest incidence, followed by the red color, and then orange, and then yellow. And if you look into our region in this map, it is white. And that does not mean we don't have young strokes. Actually, it means we don't have enough data. And whatever data are available, it is brown in color, indicates the incidence is more than 40 per 100,000 persons years. So from this article, the incidence was more than 40 per 100,000. And actually, if you look into MENA region, it is not a homogeneous region. There is significant diversity and differences in terms of ethnicity, genetics, demographic, as well as healthcare system. But this is like the average incidence rate, which is double like the incidence rate in North America, Australia, and this is even higher than the incidence in Europe. This colleagues, it was about prevalence of stroke in young adults in the MENA region. So they have included 14 studies, and the participants included are more than 3.8 million. And I want to share some findings from this study, despite the limitation secondary to mainly the heterogeneity of the studies included. So the pooled prevalence was 3.6 per 10,000. And most of the strokes were ischemic stroke, like almost 79% were ischemic stroke. Both genders are equally affected. And very important, I want to draw your attention to the last two squares. So when they compared the prevalence before 2015 and the prevalence in the studies done after 2015, so the incidence has actually tripled. So as Dr. Katrina mentioned in her slide, so the incidence in stroke in young people is really increasing by time. And this is true in even outside MENA region. These are, I think, already presented by Dr. Katrina. So this is from US. I'm not sure if it was published by her or no, but same concept. So basically, they looked into the young age group and the incidence of strokes over a course of years. So if you look, for example, to the overall incidence, in 1990s, the incidence was around 17 per 100,000, and this has increased significantly in 2015. And it actually, both genders are affected. For instance, men, like the incidence has jumped double from 15 to 31. The same observation also from Oxford. So this is a graph, the three top lines representing young age group and the three bottom line indicating old age group. And although the older age group incidence of stroke is declining, it is inclining in the young age group. Another study about the epidemiology of stroke in Middle East. So this is a systematic review by Al-Haj and colleagues, and they have included 64 studies, and they have reviewed the literature over 35 years. And as I said, it was about stroke in general, but if you extrapolate the data in the stroke in young subgroup out of the study, the mean age was 28 to 37. Which is younger than like other cohorts in Europe and US. And in Canada, and male was the predominant factor. Again, ischemic stroke was most common stroke type. Hypertension was the top risk factor, followed by diabetes, smoking. So briefly about risk factors, already explained well by Dr. Katrina. So traditional, unique, and non-traditional risk factors, and what would one would assume in young age group you would see mainly unique risk factors, but in real world actually this is not very true because you still see the traditional risk factors. They are really common in young age group, and this is an observation that has become more clear with time. So just to emphasize on this point, these are some data from Florida, and here they have actually, just to orient you, there are two age groups. So one age group is 18 to 35, the other age group is 36 to 55, and these different color codes indicated a distribution of risk factors. For example, the red color indicates no risk factors, the purple color indicate more than 3 vascular risk factors. And as you can see in both age groups, with time, the proportion of young people with multiple risk factors is increasing. And this is more prominent in the older subgroup within the young age. Mechanisms already explained very well by Dr. Katrina. Just to emphasize again, like one would assume the mechanism will be group 4, which is other determined causes. But what we see in MENA region is, still we see the classical mechanisms, and I will share with you some data in a minute. So this is the most recent article I found in the literature, was published last month. It was done by Dr. Amal Al-Hashmi and colleagues, and it is a multi-center retrospective studies, included almost 4,000 participants from 16 centers across 8 MENA countries, and they looked into young age group defined as less than 50 years of age. So some findings to share with you. Ischemic stroke was the most common type, like around 63.6%, almost 64. ICH was more than 19%. And this is a bit higher than the worldwide figure. We know that ICH, worldwide is around 13 to 15%. CVST is another common condition found in this study, 10.4%, which is again much higher than the worldwide figure of like 2 to 3%. Also, like for example, in Indian cohorts, we know CVST is even more common than this figure. Subarachnoid hemorrhage was found in 8%. And in this slide, again, from the same study, I'm sharing the distribution of stroke subtypes across different countries. And as you can see, ischemic stroke is the dominant type indicated by the blue column. And then ICH is common in some countries, Gulf countries, like for example, Bahrain, 35%. CVST also was common in some countries like Saudi Arabia and Iran. This is a comparison table that, it's not fair to compare, our cohort studies to cohort studies done elsewhere because of different methodology and different population. But just to give you, the bigger picture and to be in the context. So here I'm sharing again some data from Al-Hashmi et al. Study, and then the other 3 are large-scale European cohorts. So the second study here, I hope the cursor is clear. It was done in 15 European countries, and so the main purpose was a screening for Fabry's disease, but we have a very useful data from there. And then the third and fourth studies were done in ischemic stroke only, and both have more than 1,000 population. I think Dr. Katrina shared some data from the Netherlands study. Anyhow, if we look into the median age, in our cohort, clearly we have the youngest median age, and then male predominant is there everywhere, but more prominent in our region. Hypertension is common everywhere. Diabetes mellitus was more common in our region, almost double the figure in European cohorts. Dyslipidemia was the opposite, actually. It was more common in the European studies. Smoking is a common risk factor. So talking about diabetes mellitus, it is very common in MENA region, and I want to share this review article which looked into the prevalence of type 2 diabetes in MENA region, and they have compared the prevalence in 2000 and 2014, and clearly you can see it's very prevalent condition, and the top countries in terms of prevalence are Gulf countries, followed by Jordan and Egypt. What is striking here, if you look into 2014, the prevalence has increased in every single country. And some countries actually have jumped. For example, Egypt was 5th rank here in 2000, but then moved to the 3rd in rank. So prevalence has increased from 12 to 18%. So diabetes mellitus is really a major burden in our region. If we dichotomized ischemic stroke and looked into the TOAST, so mechanisms of ischemic stroke, again, in Al-Hashimi et al. Trial compared to other European studies. So if we look into the large artery atherosclerosis, it was quite common mechanism in our region. Not that common, for example, in Helsinki study. Cardioembolism is another common mechanism everywhere. What is outstanding here is the small vessel disease, which was very common mechanism, even in different studies that I will share with you in a minute in MENA region. It is not that common in European studies. Other determined etiologies was a common category in most of the European studies. So in the Helsinki as well as the Netherlands study, it was quite common. Not that common. Probably indicates inconsistent workup or incomplete workup, and this is a gap or a project that we should work on. This is again looking into the distribution of mechanisms of ischemic stroke across different countries in the MENA region. And as you can see, there is a clear variability. So, for example, in Bahrain, small vessel disease was the commonest mechanism, and you remember still Bahrain was common in ICH, so they can correlate well together. And then the other common mechanisms are undetermined causes. In addition to large artery atherosclerosis. A point to mention, so in terms of large artery atherosclerosis, for example, in Egypt, they have more of extracranial atherosclerosis, and Prof. Ahmed can correct me, from the studies I was reviewing, extracranial carotid disease is a common condition. This is a little bit different from Gulf region, where we have probably more of ICAT. I know we can discuss this later on. Just to shed the light on data from some countries in the region. So this is a single center from Abu Dhabi, looking into, again, TOAST classification, and the most two common mechanisms were small vessel occlusion or small vessel disease, followed by large artery atherosclerosis. And this is from Saudi Arabia, from Mecca. Again, the small vessel disease was a common mechanism. And here I want to mention a point that was mentioned clearly by Dr. Katrina. So I don't think young age group is a homogeneous group. So probably we need to still, divide them into the younger subgroup and the older subgroup within the subgroup category. And the older the age, the probably different mechanisms and risk factors. And also the younger subgroup has, different mechanisms, including probably, genetics and other conditions. Here I want to show some findings mainly related to the non-traditional risk factors. And my apologies for the busy slide. So I highlighted the important points I want to mention. So BFO is a common condition. It was found in 1/3 of the group being studied in Al-Hashimi study. Even in other studies, it was a common mechanism that we should look for in the proper context. You remember you have pre-test probability, you have Rope score, Pascal score, and then you decide. But in the proper context, it is a mechanism to be looked for. Remember that like BFO is found in normal population in up to 25%. It was also a common mechanism in Helsinki study in over 1/3 of patients. One like drawback with retrospective studies is that like inevitably you miss data. So there are missing data, and that's why we have missing data in terms of genetics. Thrombophilia panels, antiphospholipid. For instance, out of more than 1,200 cases screened for antiphospholipid antibodies, 137 were positive, and I'm not sure how many of those patients were diagnosed as antiphospholipid syndrome, if they are fulfilling the criteria. In Helsinki study, 6% of the group of other determined etiology were diagnosed with antiphospholipid syndrome. So probably we need more data, and this concept is true when you want to look for certain mechanisms, including genetics, probably pregnancy-related mechanisms. A very important observation that I found in my literature, and it's again a point for discussion, dissection is common in European cohorts and even in US and Canada. Like it's one of the probably the commonest mechanism of stroke within the other determined etiologies in European cohorts. However, it is not reported commonly in our region. Like I was looking into different studies, and although we talk about it, a lot in theory and we screen for it, but it seems it's not reported commonly. And because of the time, I'll just move to some data on ICH, because my talk is about stroke in young, which is a broad topic. So this is an interesting prospective study done in Egypt, and they have looked into non-traumatic ICH. And then they have divided the participants into young age less than 50 and more than 50 is old, and they have looked into the different parameters and variables. So as we would all expect, ICH is more common in elderly, but when it presents as a subarachnoid hemorrhage, it is more common in young. This is an important observation. And the other observation in terms of etiology, hypertensive angiopathy is still the commonest cause of ICH, non-traumatic ICH, even in young age group, of course, more common in elderly. But if you look into the structural and vascular causes, by far more common in young age, like almost 6-fold more common in young age group, mainly secondary to aneurysms and AVM. And the third important observation from this table is up to 1/3 of patients up to 1/3 of young patients with non-traumatic ICH were labeled as undetermined in terms of etiology or cryptogenic, which is also a group that we should be careful with this label, as if we miss an underlying structural cause, they are at risk of further hemorrhage. Again, so what I'm doing in my presentation, I'm trying to shed the light in non-MENA region to have also an idea. So this is a US national data, more than 76,000 population with non-traumatic ICH, and the same finding. So with young age group, you tend to have more structural causes. Moving to the availability of treatment and the care services in our region. So in terms of treatment, again, these are the data from Al-Hashimi et al. Trial. The population who received reperfusion treatment in that study were were actually low. So this is by far low the expected people to receive reperfusion treatment, IV thrombolysis as well as mechanical thrombectomy. And these are the distribution of the treatment received across different countries. So in terms of the availability of the service, this is an interesting systematic review done in 2023, so 3 years ago, and they have looked into the literature to have an idea about the stroke infrastructure as well as the availability of reperfusion and telestroke services. So this map, it reflects the availability of the published data actually. So the green color indicates published data on both IVTBA and EVT. Blue color indicates the published data on IVTBA, and the gray color indicates unavailability of data. So if, as you can see in this slide, the major of the data are coming from North and South America, as well as Europe, some part of Asia, some Gulf countries, as well as Egypt, Australia, and New Zealand. However, as you can see also in most of, for example, African countries, we don't have data, which is by itself a finding where we should to improve our approach to stroke in general, and we should have more data. This is even more clear when we look into the availability of telestroke services in the region. So here, this green colors indicates the data published on telestroke services, which is now standard of care. So as you can see, it's mainly clustered in North America, Europe, some pockets in Asia, Australia, as well as New Zealand, and no green dots in our region. So no data published on this. This is an interesting study done to again look into stroke infrastructure and facilities in MENA region. So what they have done, they surveyed 16 MENA countries to know the availability of the stroke service in the region, and they come up with this map. So there is, a clear diversity in the healthcare systems in terms of approaching stroke. So this, just to orient you, the stars here indicate certified stroke units in the region, and as you can see, we have only few certified stroke units, and then each indicate general hospitals. So in some countries they are relying on general hospital to manage stroke patients. In some other countries there are stroke units, stroke links, but still they are not certified yet. So there is some diversity in terms of the healthcare system. This is my last section, so some conclusion. I thought these are the main domains and pillars that we can work on to improve the service for stroke in general, and of course young age group will be benefited from the improvement of the service. So I thought of establishing regional stroke registries is very important to harmonize the database for surveillance, benchmarking, and healthcare planning. Probably we need to follow some algorithm and flow charts, and Dr. Katrina has really shared a very probably practical flow charts that can be adopted so that we all speak the same language. We have seen vascular risk factors are common and getting more common with time in young age group. So we should improve our public awareness through campaigns and initiatives. We should improve the primary, primary prevention by empowering the primary healthcare system, detecting and managing the risk factors. And of course, we should expand the stroke system of care, including telestroke services, hyperacute management, reperfusion strategies, and multidisciplinary advanced rehabilitation facility. And of course, we will need to design high quality and prospective data that are more specific and relevant to our region. I'll just end up with this statement. So young stroke in the MENA region represents not only a growing neurological burden, but also a major socioeconomic challenge affecting individuals during their most productive years. Thank you, everyone.
Thank you, Dr. Muammar, for this nice presentation. You made it conclusive and direct to the target. About your point about prevalence of extracranial or intracranial atherosclerosis, I think it's different among Egyptian population. In north of Egypt, it's different from population in south of Egypt. Also, it's different among studied population. If you are studying young people or old people, so you can say that atherosclerosis is more common among extracranial vessels than intracranial vessels. Among Egyptian population, you can say, for example, it's more common in south of Egypt or in north of Egypt, because we don't have till now a comprehensive study investigating the pattern of atherosclerosis among whole Egyptian population. We have scattered manuscript either from Cairo region or from south of Egypt. Studies from south of Egypt saying that yes, the pattern of atherosclerosis among extracranial vessels is more common than intracranial vessels, and the scattered studies from Cairo are sometimes conflicting. One study said that the pattern of atherosclerosis among intracranial vessels is more prevalent than extracranial, and the other study with fewer number of patients say now it's more common in extracranial than intracranial. So I think we need more comprehensive studies about population in Egypt. Among stroke, in young Egyptian adult, we have a nice interesting paper about the stroke among young Egyptian adult. It's published in Neuroepidemiology. I was the first author, together with the colleagues from Harvard School of Medicine, about clinical characteristic, functional outcome, and socioeconomic pattern of stroke among young Egyptian adults. We found that in males, young Egyptian males, 15% has large artery atherosclerosis, 15% cardioembolic, and 26% has had small vessel disease. And in women, 33% had cardioembolic stroke, and 5% large artery atherosclerosis, and 18% small vessel disease. So even in young populations, different between male and female. So thank you for your nice presentation. And I think now we invite our speakers and my colleague, Dr. Sebi, to open their camera and receive the questions from the audience.
So if anyone has questions, you can type it in the chat. Maybe we can take a couple from the chat. Dr. Muammar, this was essentially a whole talk, but maybe in one or two, kind of big picture conclusions, what would you say is the biggest factors for young stroke in the MENA region? Because one of the participants is asking, what is the major risk factors? Is it uncontrolled hypertension? Is it our lifestyle?
So like from my review, as I said, I mean, it's depending like what age group exactly you're talking about. Is this the younger subgroup or the older subgroup within the subgroup, the young subgroup in general? But I think no doubt vascular risk factors are becoming more common and common. Probably also the emerging risk factors presented earlier by Dr. Katrina, the air pollution, the stress itself, they are all contributing. But atherosclerosis, small vessel disease, cardioembolic remain probably the three top most common risk factors that should be looked for carefully. And very, very important. I mean, one thing that also I think we should work toward is, having a harmonized workup for patients who we couldn't capture the mechanism after the first and second line workup, because there are, rare mechanisms, and in the region we are not doing much of genetics apparently, so we are not seeing those rare mechanisms. So yeah, I think we should have some sort of consistency in terms of approach to this group. But to answer your question, I think still vascular risk factors are the top mechanisms and top risk factors for stroke, particularly ischemic stroke. Hemorrhagic stroke, like my own observation, in my center and in the country in general, hypertension, hypertensive angiopathy is also a very common mechanism of ICH in this young age group. So back to the same point. We need to have more of screening for those risk factors, active screening. Like for Oman now, we have moved the national screening program for non-communicable disease from 40 to 35 as a step, so that we look to capture those risk factors and manage them actively.
Thank you very much. I agree. I think, although we are discussing young stroke, I think the same cardiovascular risk factors, there's a very high burden over here of uncontrolled, undetected cardiovascular risk factors, which still I think needs to be the cornerstone of both, primary prevention and secondary prevention. One interesting point, the next MENASO webinar is looking at a very important and interesting topic of climate and how it relates to stroke. So some of the questions related to climate, please attend next month's webinar. I think that will shed light. And lastly, Dr. Katrina, from my side at least, can you shed some light on the cryptogenic rate in young stroke? It's still about 25 to 30%. How do we are there gaps in this? How do we get better at detecting so that we can more effectively do secondary prevention?
That's a good question. And I think that's one of the things that, the stroke phenotyping system group in 2025 was trying to address. So one of the things that they included, they recognized cancer-associated strokes as a mechanism, PFO-related strokes. But still, even with this ESUS 2.0 definition, we're still ending up with patients who have ESUS as a diagnosis. And one of the things that we've kind of learned as stroke neurologists is sometimes you just have to keep following up your patient. Sometimes it will, let's say you do like a 24-hour cardiac Holter and that's still negative, but you're highly suspicious of cardioembolic. Then you do a 48-hour, a 7-day one, a 2-week one. But the point being that you just have to keep on following up your patient. And what we say is sometimes both you and your patient have to be uncomfortable with sort of the unknown and sort of holding their hands and saying, eventually we'll find out. But sometimes either only time will tell, additional tests, but there's really no one solution. Clinically though, when we see the patients, what we do is we just say, we'll follow up, we'll try to do additional tests. But right now we have to live with this sort of uncertainty as to what's causing it.
I think there is another question talking about lack of physiotherapy and rehabilitation among young stroke patient, and also psychological support. He speaks specifically about Northern Emirates. They are lacking adequate physiotherapy. So what steps we can take to address this gap in delivering rehabilitation and physiotherapy to young stroke patients in the MENA region?
So I
Dr.
guess,
Sebi, you are working in Emirates.
yeah, so I guess I can take this. So I work in Abu Dhabi, which is a separate emirate.
Good.
And this is a huge point, right? We do all this great work of detection and treatment and, secondary prevention, but the big part of
I think
physiotherapy tends to
we need to
be,
increase awareness among neurologists and developing more multidisciplinary teams to integrate physiotherapy and rehabilitation very early. I think we need also to expand the training opportunities for physiotherapists, because I think we need more physiotherapists and occupational therapists, and using telerehabilitation in region like Northern Emirates, where there is lack of adequate number of physiotherapists.
But all of these are well taken, but I think one important thing is to work with the regulators and peers to create bundles so that they are entitled to receive physiotherapy. And because eventually, I think a lot of it comes down to payment and how much can our patients afford to get a structured rehabilitation program. I think it's very important to unify, organize yourself so that, the regulators and peers can understand the burden of this on a societal level, and actually giving them good physiotherapy is beneficial for at many different levels. So I think that is also quite crucial. I know it's past time. We have 330 odd people still online. One question: we need a consensus definition for stroke in young. Question about ICH. Yeah, maybe Dr. Katrina can take this. So this was your first slide. There's still a lot of variability about stroke in young. Go ahead.
I think we can agree that, for example, with all these classification systems, like 18 to 60 years old or 18 to 55 in most. But the point being that if you're less than 60 years old, the point that we want to make is these patients need a more expanded workup, not just your typical, because, if atrial fibrillation, atherosclerosis, this is more common as you age. But the point of having this definition, I agree, it would be nice to have like a specific definition, but at least clinically, the way we apply it is, for example, this 39-year-old patient, we would still count this as a young patient. So we would expand the workup, not just, your typical hypertension, but we would also probably include, are there any vascular malformations, for example, or even if, for example, the patient has intractable hypertension, could there be a secondary cause for hypertension? So keeping that in the back of our minds that if the patient is young, please look for other factors that might be causing their stroke.
Dr. Ahmed, I think a couple of questions regarding genetics. I don't know if we have data on this. What is the most common genetic stroke syndrome in MENA? I'm not sure we have data on this.
I think so, yes. I think also MENA is not homogeneous because there is difference between Gulf region and North Africa. Even in North Africa, there is a difference between, for example, Tunisia, Morocco, Algeria, and Egypt, and Sudan. So I think we are not homogeneous. So that's why, for example, that the prevalence of ICAD is more prevalent among population in Gulf region than population in North Africa.
Yeah, but the ones you typed out, the attendees typed out, are common. We do see a fair amount of CADASIL, at least in UAE. Okay, I don't think there are any more questions. Dr. Ahmed, do you want to talk about CME?
So thank you all for being with us today, and it has been a truly informative session, and we appreciate your participation and engagement. And I'd like to inform everyone that the evaluation form for the webinar will be sent to you within the next couple of weeks. And once we have completed and submitted the form, you will receive your CME certificate. Thank you all for joining us today. And I leave the floor for Dr. Zibijo.
Yeah, I agree. Thank you for all our participants, and thank you specifically to our speakers, Dr. Katrina Ignacio and Dr. Muammar. Very, very informative session. So let me leave you with this. This is, of course, the MENASO Congress, which will happen in Kuwait. This is our 11th edition, which will be held on 8th to 9th of October 2026. So please mark your calendars. The event is going to host the leading, regional experts, international experts, scientists, researchers, and it'll be a great time to network, to meet each other, and advance our field. So again, thank you to our speakers. Firstly, thank you to all our attendees. Thank you for MENASO, the IT team, for having this lovely webinar. Thank you, everyone, and have a good night.
Thank you.